joining our business to observe and to listen to what goes on. You're all very welcome indeed. If I could ask you the usual etiquette to have your cameras and microphones turned off, please, and respect that the text chat column thing is indeed part of the meeting. So I'd ask you to resist from posting any issues in there. I've apologies for today's meetings from Claire Hennigan, from Andy Curran, and from Caroline Donovan, and I think Jenny Hannon's here to in Caroline's stead. Welcome, Jenny.
Thank you.
I've not been notified of any new conflicts of interest or new declarations of interest to items related on the agenda, but if members of the board feel at any point that they need to make other board members aware of what might be a perceived or an actual conflict, then please raise that at the time in making your contribution. We come together today at a time when the demands on the service, the health and the care service in the broadest sense, are high, partly due to the ongoing care response to COVID positive patients, and in part because this is always the time of year in which respiratory and other illnesses spread more quickly and lead to more demands on primary and indeed secondary care. Our focus, therefore, today is very much on, in the first part, our system preparations and organisation to manage over the next few months, the winter period. And our job coming together in this board, I think, is to look at this from all sides and to satisfy ourselves that all parts of the health and care system are, all the moving parts in that are aligned and organised in the best way that we possibly can across the whole system to enable us to manage the pressures and demands through this period of time. I'm very conscious that the agenda crowds out a bit some of the more strategic and longer term discussions that have been a constant thread through this board and around our population health priorities and around some of our bigger clinical strategy issues that we've discussed here before. But right at this moment, I think that the right focus for us to have here is on the immediate next period to make sure that we get that right. We also, on our agenda today, have a further and probably final discussion on the place-based arrangements, the place-based partnerships, the governance and leadership that Andrew and Jeff will lead us through. As the weeks tick away and we get closer to the 1st of April and the new ICB and ICP subject to legislation, the place-based partnerships, as we've discussed many times, are vitally important, probably the most important part of the setup of the new world, and we need to consider fully today the proposed arrangements for governance and leadership there, and if we're satisfied, then we can move on into implementation. I'm hoping that at ICB and ICP level, as well as at place level, we can now start to think our way into the new organisational structures and new roles and begin to operate them in shadow form from early in the new year, 2022 at the latest. So we've important business to get on with, and I'll pass straight to Andrew.
Thanks, Chair, very much. Morning, everybody. There's just a number of key messages from me this morning. We've previously kept the board up to date with the progress of the vaccination programme, and clearly during the autumn, we've moved into a new phase of the programme. Just to give you some headlines from that for today, at this point, we've got a number of lines of activity. So firstly, in relation to schools and the vaccination offer to young people aged 12 to 15, 60% of the schools in the patch have now been visited, and there are plans to visit the rest of the schools in the next few weeks. And also the offer for vaccination has been extended beyond the school venue to other venues and walk-in centres. So it means that there's a greater chance for that group of individuals to receive a vaccination. For people who live in older adult care homes, again, a very significant visiting programme going on there, particularly to provide the booster vaccinations, and also activity taking place in residential homes as well. The booster campaign itself, so for those parts of the population that are able to access that, we are at 54% of people having taken up the offer of booster, and that figure is rising. And altogether, that means that at this point in time, we are one of the best performing systems in the country, looking at those different elements of the vaccination programme. So good news at this stage, but obviously more work still required. Again, I just wanted to mention that our vaccination team, who we heard from a number of times during the year, they were successfully shortlisted as finalists for a national award, the Nursing Times Award, and the category of public health nursing. So we didn't win the award, but just to be in the event and to be a finalist is a great commendation. So congratulations again to Jane Scattergood and to the wide range of colleagues that were involved in that work and therefore part of that recognition. On other issues, I'm pleased to say since our last meeting in public, the partners in the ICS have launched a Health Equity Commission for Lancashire and Cumbria. That is a piece of work where we're beginning to look at the issues of health and health inequality. And we are very pleased to be working closely with Sir Michael Marmot in that Commission's activity. Michael Marmot is an international leader in relation to issues of health equity, and he is lending his support to us in doing that. The Commission has been established. It's moving into an evidence gathering phase. There is a session for senior leaders tomorrow with Sir Michael Marmot to talk further about some of the challenges that we're facing. I will arrange for the board to receive a more detailed briefing on the scope of the Commission at a future session. We are going to pick up, as the Chair has said, we are going to pick up matters relating to the creation of the Integrated Care Board later in the agenda, but perhaps just important to say at this stage, we are about to issue adverts for non-executive directors in the ICB over the next few days. And so we're hoping as part of that process to secure experienced non-executives to add to the Integrated Care Board and to begin to represent different parts of our community and different parts of the system. So worthy of mention. I did want to indicate with relation to item 6 on the agenda, the proposals for improving primary care access. We've brought the submission summary to the board today, but we were required to submit it last week. And because the request that there was oversight from the ICS board in the submission, we arranged for that to be done on the basis of Chair's action. And David Forry and I met with the primary care team to review the submission before it was made. So when we consider that formally later in the meeting, I wanted you to be aware that we had submitted it with that level of Chair's scrutiny beforehand. And finally, in relation to our executive team, our current executive team, we are about to make a small shift in portfolios amongst the executives. We're asking Gary Raphael to play more of a role in helping us to complete the setup arrangements for the Integrated Care Board. And to enable him to do that, he is going to hand the finance portfolio in its entirety to Sam Profit. Again, very much as part of our transitional arrangements, but just looking at the balance of work that we need to do. So with effect really from this first part of November, there'll be a handover process from Gary to Sam in relation to finance. Gary will continue his work on planning that you're going to hear about in the agenda, and some of his support for digital and estates issues. But I wanted to be clear about that now, and then we'll obviously send some follow-up correspondence. That gives us the opportunity to thank Gary in this board, in this room, for all of the contribution he's made to the financial planning, recovery and approach to system finance over the last few years. And we'd like to pay tribute to that and thank Sam for her willingness to take this up over the next few months as part of our transition. Chair, thank you for that. Those are the key messages this morning.
Thank you, Andrew. Right, let's get into our agenda for the day then. We've got the minutes of our meeting on the 1st of September. You'll remember the meeting we had, we discussed the current issues around finance and plans. They're on our agenda today. We had a very good item led by Peter around the VCFSE role and its ongoing role in our partnership and thinking it into the new world. And we had a new hospitals update, which we've got further today. I don't think there's any specific matters arising, Andrew, that we need to pick up out of there. Most of the action log items are now closed. Can we adopt the minutes, please, on the formal record of the meeting? Martin first.
Yeah, thanks, Chairman. It's a very minor thing, but in the minutes has me down as Chief Executive for Lancashire Teaching Hospitals. So I wouldn't.
Did no one mention that to you, Martin?
No, I wouldn't want to step on Kevin's toes. So it's just a slight amendment. Thank you, Chairman.
Thank you. Yeah, apologies for that, Martin and Kevin. Right, let's move on into the substantive agenda then. Item 5, preparations for winter. Back to you, Andrew.
Yeah, so very much a short introduction from me. As you indicated earlier, we have updated the sector reports that we were discussing in our last meeting, just to give board members the latest position. So thank you firstly to colleagues that have contributed to the updates here. We have updates in this paper for urgent emergency care, elective care, care sector and mental health, but our following paper on primary care, which contains that submission for primary care access, allows us to talk about the issues in that sector as well. As you can see from the cover paper, we have identified a number of common risks. As we approach the winter season, we are taking actions to try to mitigate those risks. And they require both individual organisational activity, but they are also requiring significant partnership activity. And there are a number of examples given in these papers around that. We're clearly part of a national dialogue around how we explain what's happening in services. We try to make sure that there is clear communication with patients and the public about how to access the most appropriate services for them as well. We remain very conscious of that and may touch on that as well. But I think, Chair, if you're content, I will assume that the paper has been written. Let's see which questions come through this, and it may be that different colleagues in the room wish to respond given their own leadership roles in the system. Thank you.
Thanks, Andrew. Let's just run around one or two of the board members just for their perspective on where we're at right now and how things are developing. Aaron and Kevin and Martin and Tricia, perhaps you could just give us a quick perspective, please, Aaron.
Thanks, Chair. So I think this year more than any other, the A&E delivery boards have been looking at winter resilience and preparation earlier than ever. So we started in the Bay in April, May, starting to design and build a series of interventions to see us through what we knew then would be a tricky winter period. So we've looked at our plans from the perspective of all partners: primary care, mental health, social care, acute and community. And we have a composite action plan that points at all of the areas of urgent care, whether that's admission avoidance, flow through the hospitals, discharge arrangements, or what we call bridging services for things like hospital home care or discharge to assess. So we've got some additional investment for the winter, which we're just reviewing in light of two things: impact and return for those investments, pointing at the levels of risk, and cognizant of the financial position we find ourselves in H2, just to have another look at whether the kind of the return we're expecting is in place. And we've got our, I'll call it our final A&E delivery board, looking at preparations for winter next Thursday, where we'll kind of agree any further changes we need to make as we head into this period. So I think as a system in the Bay, we've approached all of the areas that we should, and we've got a good partnership owned plan. That said, I'm chairing our trust management group this afternoon. We'll be looking at the risks still associated with winter. And I think we still need to keep a weather eye on the progress on winter delivery and mitigations over the next 3 or 4 months, Chair. But a strong position in terms of preparation in the Bay, but recognise there's still outstanding risk as we head into the winter period.
Thanks, Aaron. Kevin, and then Martin and Trish, how does it look to you guys?
Thanks, David. So I recognise all of the preparation that Aaron's talked about, and you know, I think our systems have worked well in terms of preparing for winter. It's been a whole systems approach, including local government colleagues, and from a planning perspective, you know, we can take a degree of comfort in terms of where we are. However, we do know it's going to be a really difficult winter, and it would be wrong not to recognise that. You know, we are seeing still large numbers of COVID patients coming through our system. We've had a particularly difficult couple of weeks around paediatric presentations, and we're doing all this at a point where staff are really, really tired. So we've got to look after our staff this winter. We've got to keep our system safe through the emergency work and preparations that we've done. And we've also got to continue to do the work that we need to do around elective recovery. Now, we will do it and we will manage this, but I think we just need to recognise that the systems at the moment are incredibly pressurised. Last week in particular was a difficult week with staffing, and all the work that we've done means that we can mitigate, and we will mitigate the risks that we are facing going into winter. But I think as a board, we just need to recognise it will be difficult, and we need to support our staff as best we can through the next few months. So we're in a decent place, David, but recognising the risks that sit there.
Thanks, Kevin. Martin.
Thanks, David. Yeah, I'd concur with what Aaron and Kevin have said. Linking back to sort of your introductory remarks, David, it does feel like it's gone up a notch in the last week or so with, you know, respiratory illness, etc. We've had a very challenging start to the week. As Kevin said, you know, currently we have 2 wards worth of COVID patients, so you know that puts a different context in terms of dealing with the, you know, the pressures that are coming in. I think we're doing okay in terms of ambulance handovers. We've obviously had that letter at the moment around, you know, minimising them. I think we do okay. I think our level of discharges remain high, so I think we're working well as a system. But the acuity and numbers of presentations at ED are going up. And I think, you know, we are looking very much around how we sort of involve community services at, you know, at the front end to stop people getting in the system, admission avoidance schemes, etc. So it definitely does have that feel over the last week or so. Things are starting to crank up, but you know, the planning's there, the winter planning's there, etc. But yeah, it's pressured at the moment.
Thank you. And Trish?
Hi, yeah, so a very similar picture at Blackpool to other colleagues. Really, I suppose as somebody new coming into the system, I have been impressed in terms of the approach to winter planning, about all the partners being around the table and ensuring that all the plans sort of are matching up. But you know, the sort of extreme pressures we're facing at Blackpool at the moment is around that increase in COVID patients. So we're seeing that go up quite sharply in the last couple of weeks. So we've got around about 87 patients now who are positive, and obviously that comes with the challenges around flow. And the second challenge really here is we have a large amount of patients that can't quite go home but need a sort of step down intermediate care facility, and that's something that we're struggling, and that's not for any want of effort from system partners, but it's in terms of, I think Kevin alluded to, the workforce issue is a real challenge for us in terms of having the capacity and supporting the workforce. But in terms of some of the pathways, some really good work done here around mental health pathways and same-day discharge. But it is the perfect storm of the complexity, the COVID positive, and trying to get people out in a safe manner. I think is going to be a challenge. And just like everybody else, we continue the elective work because that's got to have as much focus as everything else. So challenging, but we're continuing with our system partners.
Thanks, Trish. Jenny, is there anything you want to add?
Thanks, David. No, I think just to note, we're seeing a real surge in demand as well, and recognise we're in a difficult period now, and we've got a difficult period ahead. So we're working through that and recognising what we can do also in support of the wider system to support the pressures there. And so we'll be focusing on our mental health urgent assessment centres, our initial response service and street triage to try and manage some of that demand coming through. But you know, for us as well, echoing colleagues, workforce and recruitment of workforce is a key risk for us at the moment.
Thank you, Jenny. I'd like to just, again, I like these short, sharp updates. Look to colleagues, but Jeff and then Peter, Gregory and Lindsay, how this looks to you. And then Neil, Jack, I don't want to put you on the spot on behalf of all local government partners, but would really just welcome a perspective from you on how it's feeling right now and how the next few months look. But I'll go Jeff, then Peter, then Lindsay to start with, please.
Thanks, Chair. I think with regard to the internal pressures, and I suppose I can speak mainly from a Morecambe Bay perspective, but from the internal pressures from what's going on as described in the paper, I think so far general practice is rising to the ask. Every practice is tackling it in a slightly different way. So some are sticking with total telephone triage, others are going to a mixture of straight bookable, face-to-face, etc. So there's a mixed response, but I think they're coping. I think the thing that's really difficult for GPs is coping with the external pressures from outside the system. So we've had a sustained problem with the media, which seems to have calmed down. So that's really welcome. We have ongoing friction between our profession nationally and the government, and there's probably truth on both sides, so that doesn't help the situation. But I think the biggest thing that concerns me, and I'll give a little story maybe, is the biggest concern to me is about patient expectation and understanding about what's going on. And that's not to criticise patients. It's just a fact, because patients are finding life very, very difficult through lockdown. They've had enormous traumas to themselves, physical, psychological, financial. So we understand why patients are in a difficult place. But that lack of understanding to a degree, and that expectation does create probably one of the biggest pressures, I think, on general practice, and causes to quite a lot of friction at the interface. Some things that would help would be if patients didn't believe if they didn't believe that the pandemic was nearly over. You know, I think there's a degree of complacency that we don't need to wear masks anymore. We don't need to keep our distance from people. You know, that we've had our vaccines. Well, I'll tell you what, I've had 3 vaccines and I've got COVID this week, and I felt rough at the weekend, and I've had 3 vaccines. So that it's still here. It's still a major risk to people. It's starting to emerge. It's a risk to some children as well. So we need to remember that this is very real. And finally, I would finish by saying, you know, the last time I was working clinically a week or so ago, seeing lots of patients with respiratory symptoms, when I asked the first question I asked them, when was your COVID test negative? And virtually none of them have had a COVID test. So there's a degree of reluctance to accept that the symptom I have got as a patient could actually be COVID. No, it can't possibly be that. Well, I'll tell you something. I can't tell whether a patient's got COVID or not when I just see them and examine them clinically. I can make a good guess sometimes, but I can't tell. So I need that test. So there's something around the messaging to the public with understanding, because as I say, I think they've been under great pressure. So I understand where they're coming from, and they've got lots of suffering, pent up suffering, and problems stored up. So it's not about criticising patients. It's trying to establish a deeper understanding about where we are with the public. That's a bit my thoughts.
Thank you, Jeff. Very helpful. Peter.
Thanks, David. Yeah, I mean, I very much agree with everything that Jeff has said, and I suppose all I can do is, I mean, the experiences in West Lancashire are the same as they are in every place. It's that age-old problem of demand is greater than the capacity that we have. I know primary care is the front door of the healthcare system, or what I'd say at the moment is the door isn't big enough for the number of people knocking on it. So it is pressured, and there's no doubt that the media has certainly had a significant impact on morale. We do. I think we have to acknowledge that there is some variation in what is provided, and that it must be incredibly frustrating for our patients and the population that use us. But it's not helped by the conflicting advice that we've received nationally in terms of how we are to manage our infection control guidance, and the seemingly ever increasing demands on what we need to do. Primary care was always, and the NHS has always been a needs-based system, but we've moved very much to a consumer-based model where we are providing services that perhaps we don't feel we need to, and I think that adds to the challenge, and that's something that we perhaps need to nationally address somehow. So yeah, so that's how it feels. I think also my worry, and I know this is shared by other primary care colleagues, is that when we look at the data and the national drive is to focus on so-called underperforming practices, my concern is the overperforming practices, the fact that the vast majority of practices are delivering more appointments now than they did pre-pandemic, and that's with the same level of human resource. We're trying to maximize the use of additional roles, we're trying to signpost people to community pharmacies, but those overperforming practices, I worry about their well-being, and I think that's something that we have to consider more as we move forward.
Thanks, Peter. Lindsay?
Thanks, David, and apologies, I was late to the meeting this morning. I think very much echo what has already been said. I think the mental health and well-being of our staff is a significant concern, I think, at the moment, and we are seeing more and more staff turnover across practices, and certainly that's been a feature in central Lancashire over the last few weeks, is a number of reception staff in particular that are leaving, and still the ongoing level of abuse that our staff are experiencing on a day-to-day basis. And that's for a whole range of reasons, and obviously, as Peter has already said, around the amount of capacity that we have, it's just not physically possible to offer an appointment to every single patient that rings up on every single day, because we just don't have enough clinicians to provide that. So I think, pressures continue. I think very much, and I know Peter has been doing a lot of work around wellbeing across primary care and how we can understand that better. But I think that for me is one of my primary concerns at the moment, is that through winter we know things are going to get worse and harder, and people are going to ask more of people. And I think when people are already feeling under significant pressure and stress, that is a real concern.
Thanks, Lindsay. And Stephen, you want to come in?
Hi, yeah. Having delivered most of the nation's COVID vaccinations and still cope with the pressures of COVID over the last 18 months, there's real palpable anger in the profession, particularly around sort of Sajid Javid's media-fed links to percentage of face-to-face appointments in primary care, and especially with the suggestion that access to the funding for supporting primary care will be linked to that. Thus, the underperforming practices will not receive any funding. To the extent that the BMA is currently in the process of balloting GPs on taking industrial action as a response to that, the proposed action is to completely withdraw from the primary care network process. Now, as primary care networks do seemingly form quite an important part of the NHS going forward, that would be quite a substantial hit. It isn't something that the local LMCs particularly support, as we've feel that the local PCNs have done some very good work and have the prospect of doing more, if only continuing with the COVID booster vaccination programme. But it's a real, genuine concern, certainly nationally, that the disengagement of from PCNs could substantially affect our ability to cope in future. There's been what I think is particularly concerning is this focus on the underperforming practices in terms of face-to-face appointments, because it really is such a blunt tool to use in order to measure what the quality of primary care. There are plenty of practices out there who actually provide superb services by providing mainly triage and only seeing those patients who need seeing, but for longer periods of time. There's lots of little bits of information in this sort of the stuff that's come out centrally, which is just likely to make the whole thing fail. The capping of locum payments to £80 an hour, which is actually less than the general going rate at the moment. So, you know, I can't see how we're suddenly going to get lots and lots of GPs to come in and do all this work. And so I think locally, I don't know that we're going to be have a particular problem with that, but nationally, I think we are. What concerns me most about this is the lack of a clear plan either nationally or regionally to actually manage patient demand. I know it's been mentioned before, but we'll see in Peter Tinson's later paper, sort of the amount of money being spent on the winter pressures in primary care. I can't see anywhere in there about a big advertising campaigns to saying to patients, look, this is why we're having problems. This is what you can expect. You may not get a face-to-face appointment just because you want one, but by telephone triage, you may get one if you need one. So, you know, all these little bits of funding that go out probably would have been better spent on something more major in terms of advertising. So that's my comment.
Thank you, Stephen. It's very clear. Completely understand the perspectives which you represent. And we need to see where all this goes in the next near future. I think the PCN work has been so vital through the whole period that's got us to here, and we build our intention to build on that further through this transitional period into next year. If that was disrupted, it would have a big
yes
and difficult impact on us. I worry about that. Thank you, Neil. If you're there, just add to this sort of stock take of how it feels where we are now.
Stock take of misery. Just in terms of some of the issues that we're seeing, I mean, Tricia's already mentioned some of the issues in Blackpool and the Far Coast, but services were fragile before all of this. So if we're thinking about residential care, particularly around more complex needs, sort of EMI beds and what have you, and care at home, those services were already fragile. So the staffing issues we're seeing as a result of the pandemic, both in terms of loss of staff through that, but also about pay rates. The Amazon driver thing is real. People are leaving the care industry, particularly those drivers in the care at home industry, to go and work for Amazon. That's genuinely happening. So the staffing issues are significant. I think in terms of things like the potential for staff being lost because they won't get vaccinated, it's a bigger issue across Lancashire than it is in Blackpool, but still a significant number of staff who could disappear from the industry because of that. We're also seeing extra complexity of health needs on discharge. So it isn't just about having beds or intermediate care, it's about a more complex set of needs. And that is difficult to staff up. I think looking at some of the other issues that we've got, I mean, it's worth remembering that our adult social care demands are not only driven by hospital discharge. So we do have to manage a lot of other demands as well, trying to manage the additional pressures that are coming out of the discharge side of things. One thing also across an ICS issue is we can't assume that the pressures and the capacity are the same in all parts of Lancashire and South Cumbria, because they're not. The issues are different. The investments that have been made in different parts of Lancashire are different. So let's not make an assumption that we can have an ICS answer to this in terms of local authorities and adult social care. Financial planning is enormously challenging. We don't know the detail of what finances we'll have available next year yet, probably not for another few weeks, even though the review was announced last week. And we will not have enough money. Regardless of what is allocated to social care, even if we protect it, the financial issues that most local authorities are facing are significant. You can see quite a few local authorities are being bailed out across the country. So the spending pressures that we're facing are probably more significant in other parts of our business, particularly children's social care. So any financial solution to demand needs to take into account the fact that we do not have another bucket of cash to use. Most of the money from the national insurance increase is going into the NHS, not to the local authorities, for all the health and social care precept. Just in terms of the vaccine programme, we're a bit behind in Blackpool of those averages. I think we're 45, 46 on boosters compared to the 50-odd% that Andrew mentioned earlier across Lancashire. And be worth mentioning public attitudes. I think the comment made earlier about people think it's all over. People are not going for boosters in the same urgency they went for the original first two. Masks are barely seen anywhere, and the bigger issue than masks, people are making far more contacts than they were before. People are socialising a lot more. So bearing in mind all of those attitudes, the infection rates aren't suddenly going to go down unless there's a miracle occurs. And school vaccinations obviously is going to be an issue. That's not just around children, that's also around workforces as well, people being off to look after their kids. The only other thing what I think is worth mentioning is that demand management concept mentioned before. Absolutely need to be thinking about how we can manage demand down. There aren't going to be any more lockdowns, I can't see. So let's not imagine there's a lockdown coming around the corner, which is going to knock demand down significantly. I don't believe there is. And I don't believe there should be either, to be honest. So demand management is absolutely going to be an issue that we need to try and manage. And I know we're talking about winter plan today. It's already winter.
Thanks, Neil. So the test for us, I think, is we haven't got magic answers on macro funding, on suddenly being able to turn on a new supply of workforce, and in terms of the demand on the service to prevent a lot of that straight away. But there are our test for us is, are there things that between us that we can be doing better than we are now, even if it's at the margins, to improve some of the dynamics that we've just heard about. I'm going to, I think, to try and get the flow right on this, I'm going to take item 6. So Peter, Gregory and Peter Tinson and Lindsay can just talk us through that paper, and then I'll open up for a broader discussion for thoughts and reflections on if we're doing everything that we can at the moment. But let's get the improve access in general practice recommendations on the table to be part of that discussion too. I don't know who's going to introduce this item for us.
Thanks, David, and I'll start off if that's okay, and just
Yes,
give
Peter,
you a really quick summary, plus I'll take it that colleagues have read the paper. I think the first thing I wanted to do is just start with a thank you to everybody, in a sense of particularly General Practice College in terms of how they've been responding to and managing the challenges that they've been facing. What I also wanted to do is just give a really brief update to part of the paper that talks about increases in appointments. And at the time we wrote the paper, we had August's data. We've now got September's data, which I think is really telling. So in September, general practice colleagues saw just over 884,000 appointments. And that compares to 734,000 in September 2019. So for those of you who are quick at doing maths, that's an increase in 150,000 appointments between those two periods, and that's a 20% increase. So it just gives you an idea of the scale of the challenge, and again, the additional activity that's currently being undertaken by general practice. The paper, I think, is quite self-explanatory in a sense of providing you with some other background information about those pressures. Also, I think highlights that there is a wider debate here, and there is a wider debate that is taking place elsewhere around what does a sustainable operating model look like for general practice, but not just for general practice, for other community health and social care services as well. And also links to the point you just made, David, around actually what are the opportunities in terms of integration of how we work. Workforce has been a consistent theme throughout the entire call so far, and again is no different for general practice. And you'll see that we don't compare favourably in terms of primary care workforce in Lancashire and South Cumbria. Some of that needs to be addressed more nationally, but there are still things that we can do locally. In terms of the specific schemes that you can see in the paper, and again, a bit of an apology, because when you read the headings for those, it's not always easy to understand what they're about. And just to reassure Stephen Hardwick, there is a chunk of funding in there around communication, and we're looking to increase that, in fact, double that amount of funding based on what we think will be some movement in other schemes. The schemes, for me, probably thematically cover a number of areas. There's something around supporting patients to access the right services. So we've got examples of really expanding the use of the community pharmacy referral service. Also, the comms piece I've mentioned, and also a piece linked to that around care navigation and signposting, which we know there is scope to do more on. We've also got a chunk in there around, or a theme in there around, improving same-day access provision. And you'll notice a number of place-based partnerships are looking to introduce hubs or expand the numbers of same-day access hubs that they currently have. Those are probably likely to be something we'll come back to, but they also potentially represent more medium to long-term solutions. And again, I know place-based partnerships are looking at how they integrate those hub arrangements with other community and diagnostic services. Also a theme in there around investing in voluntary sector and social prescribing, which again, I think is absolutely right. I'm also conscious, and I think I've mentioned this before, that we need, again, a bit of a workforce planning conversation with our voluntary sector colleagues, because we are increasingly making assumptions around the support they can provide, and that I think needs a strategic workforce planning conversation. And last but absolutely not least is the workforce theme and issue, and again there are a number of schemes in there that are looking to improve our approaches to how we pool and did have some digital remote working around those workforce pools, but there's also purposefully quite a significant investment in there around our workforce clinical leadership and support, because we think there is more we can do locally. And I will leave it there. Thank you, David.
Thank you, Peter. Peter and Lindsay, anything you wish to add? No? Okay. Thank you. Okay, so as Andrew said at the start, this has been submitted. We wait to hear the outcome hopefully very quickly, of this process. So we've now got I would welcome other contributions, please, from members of the board in terms of that question in our minds. Are we doing everything we can within our collective ways of working and resources to put onto the table to address the issues that colleagues have raised? I've got Mike, then Graham, then Ian, then David.
Thank you very much for this report. It really answers one of my concerns about the whole agenda today, which necessarily is about inputs, not so much on outputs. It's about finance and structure. I'm thinking particularly of the items to come. And sadly, I have a sense of gloom around the place. And I think there are things we can be really positive about. Obviously, the vaccination process, in which primary care has been centrally involved, is a really important part of that. But I find myself wanting to know more about what the ICS is actually doing on the ground, what we're delivering. And this report certainly helps in that. I wrote to my GP practice to express support and gratitude for what they were doing a fortnight ago. I haven't had a reply, and I didn't expect one, but I was trying to combat what's going on in what has been going on in the media. I see in this report that there's talk about hubs in the Fylde, and that sparked thoughts in my head about another problem that we've got, which is the ever-growing incidence of diabetes. I've taken a bit of an interest in this subject as a layperson, and I'm told that it consumes 10% of the national NHS budget, and that diabetes too is growing fearfully, something like 40% in the last 10 years. And I just find myself saying, if we could find a way of preventing, let's say, 100 cases of diabetes across Lancashire and South Cumbria, would that not save a lot of money? Would it not save even millions of pounds? And I think this is something which all parts of the system embraces, from primary care, primary care networks, social prescribing, hospital treatments, and cutting-edge technologies, something that I've read about called flash monitoring devices. My question at the end of this rant really is, are these hubs meant to tackle this ominously spreading disease, or are we so understandably wrapped up in workforce problems, in money, in COVID, that we have to put these kind of things on the back burner? I hope not, because when this whole process started out, we were setting up various streams of work, stroke comes to mind, which would really make a difference. I must declare an interest because I'm a member of an organisation called Inspire, Motivate and Organise, which is working with the BAME community. And they've had funding for diabetes work, but it was a pathetic amount, limited to a very short space of time. And speaking for the sector as a whole, they need more resource. I absolutely agree with what Peter said about a review of the workforce in that sector and what it can really contribute. But it needs more money and it needs longer contracts if it's going to make its contribution, its vital contribution to our health and well-being. I'm conscious that that's a bit of a digression, but it does certainly spring acutely from the report that you've kindly given us this morning.
Thanks, Mike. Very powerful points. Peter, do you just want to come back on what Mike said, please?
Yeah, thanks, David. I first of all, Michael, thank you for the support that you offered to your practice. I'm sure that was really really would have helped. Those sorts of conversations and calls can really lift a person's day, I think. But what you speak to, I think, is absolutely the nub of the issue, which is the whole issue of the primary care responsibility to primary prevention. As you speak about obesity, absolutely, and diabetes, that growing problem, which is largely preventable through altered lifestyle and early identification. But that the demand, the kind of the the unplanned demand that comes through the doors is dragging workforce and capacity away from that sort of work. So I think that's why I don't have an answer to your problem, but I think you summate in a single case the essential issue, which I think is a system and national problem, which is how do we direct the resources of primary care to have the most positive impact, and keep that. We've got very highly qualified clinicians dealing with coughs and colds when they can manage really complex illness, and yet what do we do on every day is we deal with coughs and colds. So I think that it's a very good point. That's all I really wanted to say. Thank you, David.
Thanks, Peter. Graham Gooch.
Hello, thank you. I mean, just to take up Michael's point, I was diagnosed with type 2 diabetes 18 years ago, and I'm sure it was richly deserved. And it all is about lifestyle, and that's rather than treatment basis. Just one question I was going to ask is, it says in the papers we've got 65.25 GPs per 100,000 people. Are they actually, is that the number of people, or are they FTEs? Now, the reason I ask that is quite important, because I get a lot of complaints. I mean, doctors are under the cosh on this, but what a lot of people are saying is half the doctors at my practice are part-time. If they weren't part-time, there would be enough GPs. Now, so we need to know, are those 65 people actual people, or are they FTEs, which makes a big difference when you're doing the calculations.
Thanks, Graham. Anybody got a quick answer on that, please?
They're FTEs.
Thank you. Thank you, Peter. Thanks, Graham. Ian, then David Blacklock.
Thank you, David. It was a bit depressing listening to this these couple of items, and I don't get the sense from being within the system that people are depressed about the work they're doing. There's some fabulous work being done, and I don't think that particularly came out of the presentations. I do think we do need to make that point, that people are working extremely hard under difficult circumstances and achieving a lot with very little in terms of resource. But the questions I had really were a request for further information. I'm particularly interested in the out-of-hospital work that we're doing, and I don't think that came across in the paper to the extent I wanted it to. And the three elements I jotted down were admission avoidance, early discharge actions, and primary care capacity. And I'd be grateful for further information on those three, and whether we as a system are working together to maximise actions in those areas. And on Peter's paper, will the additional funding solve the problem in primary care of capacity? And a recurring theme that I keep getting when I'm talking to people round and about is they're happy with the service they get from the GP surgeries when they finally get to speak to the GP surgeries. They're frustrated about the amount of time it takes them to get on the phone to try and access a booking system. And I can speak from personal experience in that I had occasion to speak to my GP, and it took me a long time to get through. When I got through, the service I got was absolutely fabulous. Absolutely no complaints at all on the service. It was brilliant, but it did take a very, very long time to try and get through to them. So really the question is this going to be addressed in the additional funding?
Thanks, Ian. We'll hold on to that question, see if there's any more on the paper, and then I'll come back, Peter, to you, Peter Tinson, to respond. Got David Blacklock next, and then Graham Burgess.
Thank you, Chair. My point is really just about kind of managing the expectations of people. We've heard that possibly we need to be doing more in this area, and I suppose I absolutely agree with that. I think what we've got is we've got very tired staff, as we've heard this morning, that have been met with very tired and frayed patients, and that's pretty much a recipe for disaster, if you ask me. So I think that I wonder if we need to expedite our work around building a stronger engagement system across Lancashire, where we can be taking patients with us and really helping them to understand, all of the changes that are taking place and the pressures that people are under. But also, I think we might need to be thinking about engaging with our staff. And, we still, and I think this is happening the majority of the time, but we do hear stories of patients that aren't met with the kind of kindness and compassion that perhaps they need to feel when they're not feeling very well. And that's because we've got very tired and frayed staff. And so, that I think there's probably engagement that needs to happen in a number of different ways. Certainly, we can do more with people, and Healthwatch, my organisation, would be very happy to support and help with that. And possibly we need to do some more support and work with staff, just to really actively be demonstrating at all times that that interface, that compassion that patients need to feel and hear when they've been on the phone, as we've heard from Ian, for a long time to try and get through. You need to feel like the person at the other end of the phone is absolutely on your side and wants to be shoulder to shoulder with you. So I suppose it's an offer from me. Healthwatch would be very welcoming of further conversations, and I think we need to do something large scale that supports people in Lancashire to understand exactly where we're at as a system, so that they can have our backs, really.
Thanks, David. Very, very helpful. And I certainly think offline out of the meeting, colleagues, and you could join in some discussion, if you could, with colleagues, Peter and Lindsay and others, about how we can move forward in the way that you've described. It's most helpful. Thank you. I've got Graham Burgess, then Dennis.
Yeah, just 2 points, Chair. First of all, on a positive, I think the situation in Lancashire is solid, well organised, relationships are very good. And I would say that compared to where we were 4 or 5 years ago, I think our system is lots stronger and working together extremely well, and particularly credit to the local authorities under massive resource pressure, working with a hospital and a GP. I think it's very well integrated. That's not to say there aren't huge pressures, there are massive pressures, but we are better equipped to cope with them than we were several years ago, and the system working, particularly ratios built around COVID, but even before then, are strong and robust. So that's the very positive picture we've got. However, I must say that certainly in Blackburn with Darwin, in terms of the percentage of GPs to population, we've got the second lowest percentage in England, and it's going down. And that's the situation. I think Burnley is in the bottom 10. And I think all the places at Accrington and other places are also in the bottom quarter. So we have a situation in Lancashire where our primary care workforce is actually lower than anywhere else in Lancashire, and certainly lower than anywhere else in the UK virtually, across the population of 530,000. So my question and the challenges back to the ICS is, are you taking account in terms of your resource allocation and the allocation of ancillary staff to GPs working in your GP surgery, social prescribers, etc. But are you taking into account in terms of allocation resources the extra challenges that are being faced in not only Blackburn and Burnley, but also in Barrow and Blackpool and places like that? Or are we trying to do this situation where we have a consistent approach on the allocation resources just based on population per head, and not taking into account of the deprivation, extra challenges, lower doctor numbers in the areas of great deprivation? So it's a challenge back to the ICS. Are you taking a more nuanced response in terms of resource allocation, or are you simply doing it on a population per head basis? Because I think different areas, because of deprivation and lower doctor numbers, do have different challenges.
Thanks. So Peter Tinston, I'll come back to you now, and maybe you could pick up Graham's point and also Ian's questions from a few minutes ago, please.
Yeah, so certainly in terms of this winter fund allocation, we indeed did take a more nuanced approach. So we looked at a range of data, And again, that's system colleagues and place-based partnership colleagues looked at that data. Some of that was around access, and that wasn't just about primary care access. It was also access in terms of usage of 111, A&E. We also looked at some satisfaction data, and we also looked at the deprivation, the IMD for each individual practice. What we did is share that information, discussed it and place-based partnerships, and that critically with local intelligence was the basis of the development of those schemes. When we received those schemes and looked at those schemes, we also then, not surprisingly, took a view in terms of what's the data telling us, what's the local intelligence telling us, and you'll note in terms of the allocation of the resource that is based on the consideration of that information. So it was definitely nuanced, and you'll note it's not a straight population allocation. In terms of Ian's question, in terms of will this funding solve this, I can say with a great degree of certainty that it won't, and I think you'd expect me to say that. And I think I'd bring back in Peter Gregory's point before around consumerism, and then I'd couple that with the big issue we've all been talking about, which is workforce. Also, I'd agree with the point, Ian, you made around the vast majority of patients are really happy once they get access to primary care with the service they receive. We know we've got issues with telephony, and we have colleagues who are working to address some of those issues. And we also welcomed within the national publication confirmation that there would be a national procurement solution that would enable us to expedite that more quickly. And again, I think linked to that, there's also something that we have to acknowledge around us working with the public and patients around understanding how they navigate, and we signpost them to the right places and the right services within our system, which again is why we want to put so much of this resource into that communication piece as well.
Thank you, Peter.
Thanks.
Dennis, then Jeff.
Thanks, David. First point I want to make is maybe just a very brief reflection on what we've all been through, particularly primary care. So I think we've had the first global pandemic that any of us have ever experienced in our lives. We're not over it yet, but probably got over the worst of it. And actually, how did our system cope with that? Pretty well, actually. So when we look at public perception on primary care, we've got to appreciate that, you know, the press have got some responsibility to be sensible about what it says, but in reality, primary care's coped very, very well. The other thing I want to pick up is that somebody mentioned the issue of demand, and somebody very wise once told me many years ago that demand in primary care is like electricity. It flows down the path of least resistance. So that's something we've got to consider when we think about what we're going to do next, what we invest in, because opening new swim lanes will only mean we get more swimmers. It doesn't necessarily mean we get more effective at managing demand. In fact, we'll probably get worse at managing demand. So we'll be quite clever around, well, very clever about what we introduce and how we introduce it. I don't think we've got anywhere near using the right type of technology to assist our patients to make the right decisions. I'm not overly convinced that big public campaigns make a great deal of difference. We've seen that in the past. I can honestly say it doesn't really make that much difference. But what we're seeking to do, what do patients need when they want an intervention from primary care or anybody else? They want the removal of fear. They want to know what's going to happen, who's going to do something, how quickly can we get to the end destination. And sometimes technology can help with that, not all the time, but sometimes. So I think when we're considering what to do next, let's factor these things in. Ian's point earlier on, you know, what the biggest complaints we get, it's not about the quality of primary care, it's not about the discussion, it's not about the interaction, it's about getting an answer to how do I get in there and speak to somebody. So telephony systems are really sort of geared up for 20th century work, not 21st century work. So we need to think about all these different things. I'm not saying we build a technological solution that answers all these problems overnight, but we've got to start somewhere. We've got to think about the introduction of better digital AI processes now, so we're fit for the future. Thanks, David.
Thanks, Dennis. Jeff.
Thanks, David. Just a quick comment on what Ian said at the beginning, and I think GPs are very happy in doing the clinical work. The morale is low because of all the external pressures we talked about before. So it's a real privilege to be a GP and to be invited into a person's life and home and family. And I think actually people have enjoyed having the challenge and been able to rise to the challenge. And I think you know, I think we've all recognised that's what we're paid for and what we're here for. You know, you don't join the army not to go to war. You don't join the medical workforce not to have to deal with stuff like this. So, but my points were this really. I don't think the cavalry's coming. You know, we've got the lowest GP numbers and around, as was detailed before, and actually the country's got the lowest GP numbers it needs. And actually, that's worse in deprived communities. So Blackburn, you know, Blackpool, even Barrow. I thought Barrow was terrible until I joined Lancashire and South Cumbria. But there are worse places. So deprived communities, Preston, they're going to really struggle and struggle sooner. So the cavalry's not coming. We've been promised 6,000 extra GPs, and we're now down a further 2,000 something since that promise. So we've got an 8,000 gap. That gap will grow at the end of this pandemic because people are hanging on and hanging on and hanging on, but at some point people will crack and say, right, the pressure cooker, you know, the lid's off the pressure cooker now. I can now honourably retire or slow down because I've done my job and I've seen myself through the pandemic. And people will go. People in the mid and early 50s even will go, or more likely reduce their hours from 4 days to 3 to 2, that sort of thing. So we have to anticipate that this isn't just a winter pressures crisis. This is a general practice workforce crisis that was there before the pandemic. And so my argument would be we need a different model. We need to focus GPs on what we're needed to do and what we're good at, which is complex care, complex diagnosis, managing frailty, managing palliative care, managing chronic disease, and yes, acute presentation does need some GP supervision. But when you think about it, most of it is musculoskeletal, acute mental health, infections. Most of that can be done by other practitioners with some GP supervision and support. So we need a different model of care, I would propose, and the sooner the better. I have to say, and I would if I was a partner, I would still, and I'm not now, but I would still be the same. My profession is a bit reluctant to move because we're scared of change. I would suggest, but I would suggest that very soon, if we don't change and have a different model of care, we will drown, and then there'll be the general practice will be in a very sorry state. I very much take on the point of view of demand management that Stephen made before. There's been very little in anything nationally to manage demand for many years, really, and I think it's critical at the moment. And I don't quite agree with you, Dennis. I sort of agree with you, but I don't, because in a former life when I was in Cumbria PCT, we went to Finland, and Finland had a worse demand problem than England's got now, and they had a massive national education and engagement program, and they reduced demand massively. The evidence is there. It's an evidence-based approach. We're just not very good at it in England, and possibly a little bit better in Scotland, but let's not be too nationalistic. But we're not very good at it on these islands compared to others. So I think it can be done, and I think it has to be done, because otherwise we'll be creased. So I do see hope. I do get great joy in this job, and I do see hope. But I think we need to reorganise, and I just wonder how much we can do that, because all this money that we're going to spend this winter will help, but it won't give us more people. There aren't any more GPs out there, and there will probably be less. And when all this new wave of GPs are going to be trained come through, I bet the numbers don't increase overall. So I think assume the cavalry's not coming. Assume we've got to do it with existing resources in a different way. Thank you.
Thanks, Jeff. We've got Eileen and then Roy, then I'm going to move us on.
Thank you, Chairman. Could I, first of all, could I say I wouldn't disagree with anything that colleagues have said, you know, about their experience and the analysis offered, which overall I think is really helpful. But could I perhaps take us back to the point that you mentioned earlier, which was about posing the question, what is it that we're doing that we can do better? And I guess implicit in that is the assertion that there are some things which are having an impact, which are working really well. And so that leads me to the point made by Neil about recognising that things are different. He pointed out the heterogeneity in Lancashire and South Cumbria. So is it that we could think about what is it in throughout the area, how can we identify things which have an impact for the patch where we're all working, and that could lead to perhaps an identification of the quote most impactful for a specific area, and then focus on those which are seen to be having the greatest impact. Thank you.
Thanks, Eileen. Very good, very helpful. Got Roy, then I'll let Andrew can sum up for us, please.
Okay, thanks, David. Sorry about this. I've got a bad cold, so perhaps you'll come and see Jeff. But so excuse me from this. I don't really like anecdotes, but I'll start off with one I heard yesterday on a meeting, and this was one of our practices in Blackpool, 14,000 patient list. It was monitored one morning last week. It had 6,000 phone calls, nearly half the patient list. Yeah, it's incredible, really. And yes, we are under-doctored in Blackpool. We've tried to get more doctors in. We've used national schemes where we've had a golden handshake, where to get doctors in using a £20,000 national scheme. That's worked to an extent, but we still haven't got enough doctors in Blackpool and on the Fylde Coast. I'm sure Peter Tinson knows all that from his experience in the past. Just with regards to avoidance schemes and demand management, I think really importantly that we just need to separate the two, really. The two separate issues, demand management and avoidance schemes. We've used avoidance schemes in the past, and that usually actually puts more pressure on primary care, because the avoidance schemes are reliant on our GPs finding ways of diverting patients to other or signposting them to other organisations or other methods of care. Just with demand management, it's different. In demand management, it centres a little bit around hospitals and the flow through hospitals. And another anecdotal story I heard was that we have in some hospitals a significant amount of patients who are fit for discharge but can't be discharged. They're medically fit but can't be discharged because there's either no packages of care, no domiciliary care, because domiciliary care is lacking in staff, and it's that perennial problem that we have with staffing. So how do we move patients out of hospital into care packages, either intermediate care? We did identify actually last week the possibility, and I don't know if anyone else has done this, that there might be some spare capacity in care homes for ambulant patients, I think probably, that could leave hospital and go into a care home setting. So we have actually identified some places within care homes. Now I understand that's really difficult for patients in hospital who are either subject to COVID or have specific needs, but I'm sure there are examples of where patients can be discharged. Now the problem we have with that, and I think we all know, is that when hospitals have spare capacity, that spare capacity soon gets filled up. So you open a new ward and that ward would get filled. It was Dennis Gitz's comments before about path of least resistance. You just keep opening these centres for care, and they'll get filled up very quickly and very easily. And that is the problem. So it is a bit about admission avoidance, but it's about demand management as well. But I think we need to look at both those things in a separate, and just ensure we do not put extra pressure on our primary care colleagues. Thank you, David.
Absolutely, thank you, Roy. And finally, Andrew.
Not an easy conversation to sum up, because we're very articulate in describing pressures and problems. A reminder that a number of people have said, actually, there are things that we are doing either individually as organisations or collectively which are making a difference to this. So there are a number of very, very significant initiatives in different parts of the patch or as a whole that we are taking. A reminder also of that statistic about 150,000 extra appointments being offered in general practice in a comparative position. So sometimes the narrative that is out there doesn't actually help us to tackle the problem. I think Eileen's challenge just towards the end of the discussion is really helpful to us, because we are going to have to implement our plans. It's not just about planning, it's about the implementation, and have an eye to the short-term things that will keep us safe, that keep our nerve, if you will, during the winter, but then some of those longer term structural things that people have talked about, the nature of the workforce challenge, or the nature of a market for residential care, which is going to change over a period of time. If we are a maturing system, we're going to have to understand who needs to take the lead on those things, and how we judge the impact of what is working for us. And perhaps that sometimes our discussion tends to be more towards the discussion of the problem and less towards the discussion of the impact of our action. So I think, Chair, we've got some steer here about the way we need to assemble some of our discussion around some of these sector challenges over the next few months, so we can pay attention to the actions that we've taken and whether they're having an impact. Thank you. Thanks, Andrew.
It's very good. It's a very, very rich discussion for which I thank colleagues who've contributed. And to reinforce Andrew's point, we're managing in the day over the next period, the next weeks and months. It is going to be increasingly tough. As Jeff said, there's no magic answer for this, but I think we can be confident from both the substance and the spirit of the discussion in this meeting that the system is maturing and it is coming together to understand and support in different parts. It's also, as we manage the day-to-day, we have to capture as Andrew says, capture the bigger learning and take time to properly analyse and reflect on that for our agenda in continuing to build our systems effectively for future periods also. Now, we've let this discussion run because I think it was so important, sets the scene. We can receive now from Gary and Carl the emerging shape of the planning submission for the second half of this year, the period through till 31st of March 22. We don't need an extensive presentation or discussion on this, but because it'll come back to us next time to when the issues that are still to be worked through have been done. Gary.
I'll just say a couple of words then, please, Chairman. So since this report had been written, we've had a meeting at RPH of senior leaders across our system, comprising chairs, chief execs, AOs, directors of finance, and ops directors from all of our organisations, where we shared this perspective, and we've agreed that there is action that we can take. So it's not, I usually come up with the really depressing stuff around finance, and I feel that I need to say something that's a bit more hopeful. And I think there are some hopeful things that we can do, and I would just encourage everybody, when we don't know what the outcome of everything's going to be, it's uncertain, we have to just go through the gears and follow the process and do the things we know, how to do, continue to do the things we know, and do them well. And also since during this week, I've had some really constructive discussions with our colleagues from social care about alternatives to admission and I've given them a signal that as Lancashire and South Cumbria, we will consider whether or not there is funding available to do some of the things that we need to do as a system rather than as individual organisations, which could include some of the things that the local authorities believe could be really effective in changing the way in which patients flow in and out of our hospitals, which will be a big issue this winter. So you know, I don't, you know, hopefully the report is explains what the position is. We've moved it on this week. We do expect to get to a reasonable place. We do have the workforce constraints and the financial constraints, but there is still a lot we can do. And my message is let's go through the process. Let's get as far as we can, both operationally and in planning terms, and see where we get to, and do the things that we've done, and implement some of the new things. And I think we can still make a big difference as we move on. So I don't think I need to say more than that, Chairman.
Thanks, Gary. Kevin, can you just summarise for us where across the system where we think we're at with the elective recovery plans that you've talked to us about before, please?
Thanks, David. So all of our trusts are working really well together and providing mutual support in terms of elective recovery. We've done some detailed work together in terms of trying to particularly focus on the long waits, and then recover in terms of counter activity and what we call our P1s, P2s, which is the urgent work. So a real focus in those three areas. Clearly, as we go into this winter period, we're going to have to balance the emergency pressures against the elective work. But we're really clear that this is not a choice and a compromise. We need to do both. We need to keep our emergency system safe, as we've heard the conversations, but we also need to continue the work and eliminate our long waits as far as we possibly can. So there's a lot of planning going on in the system. We have some really good additional capacity coming on stock in the next few weeks. So what we've tried to do in all of the trusts, as far as practically possible within our estate, we've tried to separate our elective flows from our emergency flows so that we can ring fence that elective capacity and make sure it's not compromised by the emergency pressures that we've talked about. So we know we're using sites such as Chorley, we're using sites such as our Burnley site and the Westmoreland site to really focus our elective activity and really ring fence that activity. There's a lot of work going on also nationally, and we're literally, as we speak this morning, we're in conversation with national colleagues about trying to get some additional funding to support the elective recovery programme, which will clearly be welcome. So I genuinely think we're in a reasonable place, David, in terms of our elective recovery. Our overall numbers compare well, both regionally and nationally, with the work that we're undertaking. The rate limiting factor will clearly be our staff and the pressures on our staff, and that's something that we're going to manage on a day-to-day basis. But I think we're in a good place, and we will continue with our elective recovery plans, come what way may, through this winter period.
Thank you, Kevin. Graham.
Yes, I agree exactly with what Gary said about avoidance in intermediate care. This is very much something we are very keen to go ahead with, and it's urgent and it needs to be brought on apace. And we've sort of got a bit of a financial business case ready to bring forward, and we look forward to working with Gary. One bit that does cause me concern at paragraph 15 is stepping up Gold Command to 7 days working. Now, in the circumstances envisaged for this winter, I think local authorities need to prioritise the use of our senior managers to deliver services. We cannot really afford to have them drawn into Gold Command. We expect to be able to escalate the issues and consider the options exactly that emanate from Gold, but we need our senior managers out there to actually deliver what comes from Gold rather than to be there. And I understand that's something that will be discussed at the Adult Social Care and Health Partnership, but that's the only concern I have.
Thanks, Graham. Graham Burgess.
Yes, Chair. I mean, having been experienced in local government for a number of years, and also having been on a number of Gold Command roles, both in Liverpool and in the elsewhere in the Northwest, I would think it's absolutely essential that there are local government representatives at Gold Command. So I'm afraid I would disagree with the other Graham on this one. I would hope that there are local government representatives at Gold Command. I mean, you're talking about a number of senior officers. I imagine that the county Blackpool and Blackburn could do this on a rota and could share the knowledge between them. But I would think it would be a very backward step if local government weren't represented at a senior level at Gold Command. I think they're an essential partner who should be there. I really don't think that, given the number of senior officers available, a rota couldn't be drawn up between the three upper tier local authorities to make sure that representation does take place there.
Thanks, Graham. And I'm sure colleagues will work together outside of this meeting to come up with the best arrangements in view of what you've both said about that. Thank you. Are there any other questions on or observations on Gary's paper, please? Okay, thank you. Well, so we know, Gary, where it's at for now. What's the timeline for the further work that emerges from last week's system get together and from the subsequent discussions that you're having with colleagues? When will all this be finalised?
So we have to pull together, if you like, a final draft by the end of this week, and before we press the buttons next week on crunching through all the numbers, because I mean, a lot of the reason why it all seems to focus so much on organisations rather than sort of populations is really because there's some quite difficult tasks that we have to perform and make submissions to our regional teams at NHSEI. So that's where the focus is. What are all the organisations doing? You know, we and can you give us some numbers? So that's why it feels like it's focused mainly on the organisations rather than on the populations, because it's that hard requirement. So we're looking to get the broad shape of it finished by the end of this week, and early next week to have what we agreed on Friday, which is a sort of peer review check and challenge session. So we're trying to scope that and set it up with the necessary our necessary senior colleagues. We're probably looking for exec colleagues on that, so that during the back end of next week we can wrap up all the returns and make our submission to the region after that, having got to the best place that we can possibly get. So there's some frenetic discussions going on this week to see whether or not we can refine and adapt the plans that have already been submitted. So I think Kevin was saying, was it Kevin or Aaron? I can't remember who was saying, forgive me, that the A&E delivery plans, for instance, have been in gestation for quite a number of months this year. But we do need to review them in the light of the money that's actually available and the other things that we're doing in elective care, critical care, primary care, social, you know, our assumptions about what's happening in social care and working with local authorities on that. So we've pulled that all together this week, ready for the peer review next week, to inform the actual detailed technical submissions where we start putting numbers in forms and then submitting them early the week thereafter.
Thanks, Gary. Well, we can all see the shape of the planning submission, the pressures that we're trying to balance off. All this has to be done in the context of the system financial recovery, which we've discussed at all of our meetings now. And Gary, do you want to roll items 8 and 9 with Sam into a single discussion, please, to contextualise the operational plans in the financial context?
Yes, okay, thank you. So the report from the System Financial Recovery Board is it's just a report on what was considered. I think these two substantive issues on that particular board. One is that we reported that we managed to hit our H1, i.e. to the back end of September, our H1 financial target, and we overachieved it by a couple of million, which is good news. We were really concerned when we started at the beginning of H1 that we wouldn't be able to achieve this. So all the work that's been undertaken by the relevant organisations to deliver this plan is, a challenge. The first challenge that we've met this year, something that Julian Kelly, the National Finance Director, was looking for us to achieve, hopefully sets us up for a more hopeful H2 financial planning round, albeit that I think everyone on this call recognises that the second half of the year feels as if it's going to be more difficult to achieve operationally, clinically and financially. And so our H2 plan is about trying to get that right fit as best we can across the system. So that's something that we were really pleased to report. The other thing that was noted was that a lot of the savings that got us to the right place are non-recurring in nature. So they're non-recurring in the main this year and will not recur next financial year in 22-23. So it means that all the work that our organisations have been undertaking this year on those savings, if you like, we sort of go back to, we don't quite go back to zero, but we've only got 25% of those savings that we could call recurring for next year. So it gives us the problem again next year for 75% of the amount that we saved this year. But having said that, what the report mentions is that the organisation we've been working with to get us a view about our underlying deficit and what are the drivers of that deficit has now made their final report and broadly concluded that most of the savings that we could achieve as a system are indeed achievable. We've not got huge levels of structural deficit that would need years and years of consultations or lots of capital schemes or anything like that in order to get them out or to agree with other organisations what they need to do to help us. It's within our own gift to get between about 160 and 200 million pounds worth of savings out, either from support services or from the mainstream clinical services, and some big issues around the amounts that we're having to pay to agencies for staffing. So, there is a staffing issue that everyone's been talking about today. And the System Financial Recovery Board accepted those recommendations. So it gives us the mandate and the platform now to go on and get those recurring savings out. So we can start building them now in time for 22-23, so we're not in the same position as we were coming into this year, where we didn't know where the savings were coming from, and therefore have had to do expedient things on a non-recurring basis. So it puts us in a much better place, and the System Financial Recovery Board was pleased to receive that. Final point on this one, I think there was a recognition that our collective governance arrangements to deliver these sorts of system-wide schemes isn't quite up to scratch, and there is more work to do in order to stitch things together a bit better on our governance to underpin the savings. But they also recognise that in the meantime, we just have to get on with it. That's the leadership challenge, and we've got to rise to that challenge. So just moving that then into the second report. The financial side of this gives a little bit more detail on where we've got to by the end of H1. It reports on the run rates. They are a little bit up and down over the period, but generally on a downward trajectory. That's not borne out H2. They seem to go up again in H2, but certainly for H1 on a slight downward trajectory overall in trend terms. We're pretty confident we can hit our capital limit as well as a system, albeit that we're a bit behind profile this year, which normally happens on capital. But any mitigation action that's required to substitute schemes that are also priorities, we will take that action and make sure we do not allow this money on capital to go unspent as a system. So I don't know if that's satisfactory, Chairman, and I don't know if Sam wants to emphasise anything from her perspective, particularly around System Financial Recovery Board. Sam?
Okay, thank you. I think you've covered a lot of the information, Gary. I think the System Recovery Board was a really helpful meeting, and I think we had a lot of the focus really. We know we've done really well in H1 in terms of getting to where we've got to. What we've really got to demonstrate in H2 is continued progress, and I think we feel quite confident now that we can continue to take a number of actions that can help us to do that. Albeit it will be a lot of non-recurrent actions and one-off stuff. So the really important bit that we focused on in the System Recovery Board is how do we start to really put our transformational work together to start to impact on 22-23 and beyond. And so what we really focused on was the outputs of all the diagnostic work we've been doing and how that's going to be shaped into those transformational works. There's a bit of work to do around the governance. I think Ian's point before about the out of hospital is really important in that. So we had quite a good discussion about how we land all of the work that we're doing across a number of key groups. But there's a bit of work to do just to tighten up the governance around that and look at how we connect it to particularly primary care, as we've talked about today. But there's some really good opportunities for us to go at. And what I would say is that I think the system and a number of the leaders across the system are really coming together to look at this. So yes, it does feel a little bit firefighting. We've got to balance urgent emergency care winter with restoration, our staff and money, and we'll do that by whatever means this year to try and keep improving. But in the meantime, we can't lose sight, and we're not losing sight of the work that we need to do currently to start to really drive the efficiencies. We've got good data to base that on. So I think that was a lot of the discussion in the System Recovery Board, and it was really helpful.
Thanks, Sam. Ian.
Yes, thank you, Chair. Just to really reinforce what Sam and has been saying, H1 good achievement, excellent, non-recurrent. In the H2 going to be very difficult, and within that H2 we've still got to look at our system deficit, which needs further work. I think the £200 million that Gary mentioned is probably can be described as optimistic and optimism biased, but the three areas that we've got to work on: clinical pathways, staffing efficiencies and corporate efficiencies. There's certainly a lot of area to go at there, and I would just like to reinforce this. At the moment, doesn't seem to be joined up with the out of hospital thoughts, and there seems to be a gap around community activity and primary care networks, but that's something we'll be working on.
Thanks, Ian. Any other comments or questions? We started talking about financial recovery and the serious actions we needed to take as we were composing the H1 plans for the first half of this year. Those results were achieved, not quite in all the ways that we'd anticipated in terms of the recurring nature of them, but were achieved to the great credit of all parts of our system. Thank you to all of your organisations and teams. Now, though, we have, because Gary said some of the savings aren't recurring, we need to find more recurring savings in H2, and doing this in the context that we discussed earlier about the pressures on our service and the demands that we face is increasingly tough. So we've got the brought forward catch up from H1 plus the operational context that we're operating now. This is as a system, this is as tough as it's going to get for us in terms of the next steps that we need to take, but we simply have to work through all of this together and come up with the right answer in order to have a good start to 22-23. And it's vitally important that the start of 22-23 we're in a stronger position than we were at the start of 21-22, I believe. So a lot to do, as colleagues have said. back to you, Gary, then would just welcome a view from Aaron, I think, about how all this looks to this point.
Yeah, thanks, Chair. Just perhaps something I should have mentioned, and I'm conscious that this is a meeting in public. So the message is that the savings that have been identified are not about closing down services and or anything like that. What we're talking about is being able to achieve the sort of model of services that are seen in other parts of the country that appear to be more cost effective than the way our services are organised. So there is a need to change the way the services are delivered. But what the evidence is saying is that, you know, we can do that as a system, and we can go and we can go and make them more cost effective. But this isn't about cutting services or anything like that. So I think it's quite important to stress that the majority, between 60 and 70% of the total savings that have been identified fall in that category of operationally deliverable savings that could be delivered in Lancashire and South Cumbria. And it's not about wholesale change process. It's about making our existing service more cost effective and moving on from there. So I think that's quite an important aspect of what's been identified.
Yeah, very important, Gary. Thanks for clarifying that. Aaron, final reflection from you. You've been involved in all of this work. Are we doing all the things we need to be doing?
I think it's building a story that as a board we could be more confident in how credible it starts to connect to a trajectory of improvement, Chair. So I think lots of the themes we've had this morning can lead you into a conversation about how tough things are, and that is right and proper. We can't shy away from that. But there are absolutely demonstrable evidence now as a system that the way that we are working should give us confidence that when these plans start to come forward and develop, that we're in a stronger position to give that confidence and assurance on delivery than we were 12 months ago. So H1 is a good bit of evidence that as a system, in the way that we've delivered it, we have executed what we needed to in terms of the target. And the conversations now that are happening across the system with either the provider collaborative board or at place-based, there is a collective responsibility now building on organisational objectives and accountability into a system narrative, but more of a connected discussion between each of the leadership groups now on system transformation and how that mobilises. So I think Ian's reflections are right. We do need to be a bit more inclusive, I think, now on the whole of the pie chart, the whole of the spenders and ICS. And I can see the programmes of work developing to look at some of those out-of-hospital efficiencies. But I'm confident that over this next 4 months, even with the pressures, we'll start to build plans that should give this board assurance that the trajectory from 22-23 is moving more in the direction that we need it to, i.e. towards that financial improvement and run rate reduction. So yeah, confident, David. Similar to Kevin's point on, we are facing lots of challenging questions from teams on can we do everything? You know, elective recovery, urgent care improvement, system reform, financial improvement. And the answer is yes, we can and we must. That is the leadership challenge. If it was pick one and go at it, then it's an easy thing to do because everything else falls by the wayside. So I think we're getting the balance right also on holding all of those things together, David. So yeah, look forward to bringing some more of this to the board.
Thanks, Aaron. It's very good. Okay, so Gary, that was your final finance report to this board. This isn't a goodbye moment. You're going to be, I'm pleased that you're going to be around with us for the next period. As Andrew said at the start of the meeting, it's a good last report, Gary, and a good start place for Sam to pick up from here. All colleagues have greatly appreciated working with you in this capacity, Gary. You have massive respect and support in the system for the work that you've done here, and we'll continue to work with you. But I want to put on the record how central and vital your leadership in this area has been. Thank you very much indeed.
Thank you.
Right, let's move on then to talk about building the new system. Andrew, you'll talk more broadly, then we'll talk about the place-based governance and leadership.
Thank you very much. Yes, so if I introduce the first of the two papers in this part of the agenda, this is the regular overview that we provide for the board on the wide range of activity taking place. And thank you again to the colleagues that have contributed to this paper, which reflects that breadth. First thing to say, again, it's probably important to be on the record that the process of legislative change continues in Parliament. We understand the current bill of the Health and Care Bill is at the committee stage, and therefore we are making these plans with a clear understanding that they remain subject to that legislative process and any changes that might take place. So I'll put that clearly up front here. What we do as usual here is identify some of the critical activities that have taken place in recent weeks. The first, perhaps just to emphasise, in section 2, slide 48, we have continued to receive national guidance on a range of themes or topics, whether they're about building the whole of the integrated care partnership or whether they relate specifically to the NHS functions. We've continued to receive significant guidance. Perhaps most significantly in recent weeks has been the finance framework. This was long expected and gives us some more to work through in relation to the way that NHS funds will flow in the system going forward, and obviously how we then work with other partners. Finance directors have done some preparatory work ahead of the guidance being published, but they've now got more to work through, and we will again be using our governance arrangements to talk about some of the issues and implications of that guidance. We talk in section 4 about the process of building up the governance of the system to operate from the new year. A number of elements to that, but which I've concentrated. Firstly, we've been engaging recently with partners on the membership of the Integrated Care Board, the NHS body. Again, there was some quite tight national guidance around that, but we're grateful for a range of the feedback that we've had around that, and we will be considering that over the next week or two. We are obliged to go out with a further process of involvement around the broader constitution for the Integrated Care Board in the next few weeks. So that is about to start. I think the expectations are that we will plan to move to a shadow Integrated Care Board in Q4. So again, we will make those arrangements really clear to colleagues well ahead of time, and also publish them so that the public are aware of those changes during Q4. Section 5 of the paper allows our provider colleagues to give a summary of their continued work, both in the NHS Trust Collaborative and the Mental Health, Learning Disability and Autism Collaborative. So again, work accelerating in both of those collaborative areas, as you can see. There was a very helpful workshop involving a significant number of provider leaders at the end of September, which I think Kevin has spoken to us about before. There is a narrative being developed now about the provider collaboration in the same way as we've developed narratives explaining how places will evolve in our system and the whole system as a whole. So again, once Kevin feels that that is at an appropriate stage, I'm sure it will come onto a future agenda. One aspect, again, to draw out in relation to mental health, learning disability and autism, we agreed that one of the fundamental parts of taking that work forward was that we would have system strategies for those areas of work. And so again, with multi-partner involvement, there is work taking place for 3 separate all-age strategies, which will be finalised by March 22. So I think, again, we've never had anything like that in the system before, and it will be a useful driver for provider collaboration going forwards. Section 6, I apologise if you think by talking about, the names of groups and boards that we're fiddling while Rome burns. Inevitably, one of the reasons I've put this in the paper is because as the legislation is going through, it is clarifying some of the terminology that we are asked to use going forwards. And in order to be clear and consistent for staff, for partners and the public, we've just drawn attention to that today. Specifically, We expect that the name of the Integrated Care Board will be NHS Lancashire and South Cumbria. That will be one organisation working with partners in the wider system as part of our Lancashire and South Cumbria Health and Care Partnership. Again, we're asking partners to signal their involvement in the partnership by using some of our consistent branding going forwards. But again, it is partly about demonstrating a clarity of purpose linked to the legislative process. So I've emphasised a number of points, but I'm very happy to take some further questions. Thank you.
Thanks very much, Andrew. Very clear. Any questions, points, observations, please, Graham?
Yes, it's regarding, hang on, where have we gone? Oh, regarding the MHLDA provider collaboration. Now, our directors are sort of very keen. They'd like to be part of the leadership on this. Great. Because of the huge amount that local authorities invest and work in commissioning and delivering services in this field. I mean, Lancashire alone, I'm spending £185 million this year on MHLDA. And the directors are very keen on this and very pleased if they could take a leadership role.
So I think we're in that place, Andrew, aren't we? So
yes, I think so. I mean,
yeah,
very much welcome that statement, Graham. We have local authority colleagues on the transition board overseeing that work. Within that development of strategies, we also have a number of local authority directors taking sponsorship or SRO roles. So there is a level of involvement. If colleagues wish to have some further dialogue about that, very happy. I'm sure Caroline Donovan equally would be very happy to take that further. But can give you some assurance that we have colleagues involved in that work in a number of the streams of activity.
I'm grateful. Thank you.
Thanks, Isla.
Thank you. It's about system design, really, and it's something that's not in the paper. But I was listening to the conversation earlier, the really useful discussion about Wynne about primary care. And I was reflecting on what that means for our future system design in terms of how we get ahead of these challenges in future years. So I suppose my question is more of a wonder, but I wonder if at a future system oversight board, we can revisit our approach to out of hospital collaboration, just to make sure that when we look at what happens at place and what needs to happen at system level, we've got the right involved and interested involvement of care home, care providers, hospices, other voluntary sector providers, and really just to look at that again and make sure that we're designing that collaboration in a way that means we can make sure we do all we can in future years.
Yeah, thanks, Isla. Very good point. David.
Thank you. So just Andrew, on the development of the strategies, it's really great news that we're going to have kind of system strategies for learning disabilities, mental health, and autism. I suppose I just want to kind of raise a flag to encourage us not to rush the development of those things. We heard recently, I think, at the Strategic Commissioning Committee about the development. I think we need to make sure that we've got, ensure that we've got full and meaningful engagement with people who use those services to ensure that we've got exactly the right strategy. And my sense is that might be moving at quite a pace. So just I'd rather have a really great strategy that everybody's behind rather than kind of miss out some voices and so on. So I'm working, I've got a meeting this week with somebody from the transformation unit to kind of suggest some different ways that we might do that. But I think there's often a drive to get a strategy in place quite quickly, but clearly it has to be the right strategy and backed by real people that will be the beneficiaries of it. Thank you.
Thanks, David. Okay, so I think to me it feels all parts are on track. Over the next few weeks, as Andrew said at the start, we'll be starting to recruit more people to the new ICB in designate roles alongside myself. We've interviewed for a chief executive. I'm optimistic that we'll be able to confirm an appointment to that post soon. We'll start the process for some of the executive directors on the new board. Also, and then be able to to have a critical mass to work in shadow of the new arrangements early in the new year. I think that today's emphasised how important it is for us to come together as a system, both formally and informally, actually, to address some of the common challenges we face. And I want, as we build the new world, I want to build on your contributions and involve you all into the right parts of the new system as much as we can. And I'll commit to work with you all separately on that to work through it. So thank you. We can endorse the recommendations for the Lancashire and South Cumbria identity. I felt through my computer screen a lot of a few sighs and a bit of eye rolling when we talk about naming protocols and the nomenclature. I feel the same way, but I know you'll all take it properly, seriously, and adhere to the protocols that we're setting out. Thank you. Now, a vital, if not the most vital part of the new arrangements is the place-based partnerships. Jeff's been leading this throughout the whole programme. We're getting to the end game now. Jeff, do you want to talk us through the paper, please?
Sure, thank you, Chair. At risk of sounding a bit boring, because I think I've spoken to most of you about this at several meetings in several different venues, so I'll try and be brief. You all know the history of us getting here. It was a year ago nearly when we first agreed the strategic narrative. Essentially, this stage has been to agree what are the place-based partnerships governance arrangements, and this has been well aired through the partnerships. So I don't intend to go through that. The methodology has been good and it's detailed in the paper, but essentially we were given 5 options in national guidance, and we've come up with a hybrid of those options, which is, I'll remind you, a place-based leader supported by a place-based chair working through a place-based partnership committee. That's where we've got to, and this for the avoidance of doubt is we accept that this is a starting point for 22 that will mature and evolve in the following years. So that is the core of the proposal before you, which we're asking you to approve today. We're also asking you to before I say that, we're also, because in every step of this process there have been concerns and issues raised, quite rightfully, and we've tried to address those. And so more latterly we have created a frequently asked questions document, which is in the appendix, which goes to answer some of the issues that people have raised. Some of the issues people have raised we haven't been able to deal with yet, because that's included in the next steps, which is detailed towards the end of this document today, and that's around the fine detail of, so what is a partnership going to be actually doing? And of course we cover that at a high level in the strategic narrative, but it's more around the individual lines of work. How much of this will we be doing? How much will that be doing? And that needs to be defined and negotiated and agreed in the coming months. So you'll see towards the end of the document a thing entitled responsibilities and delegations, and along with that will be the financial allocations, which so all that work has now got to happen over the next few months, and of course, you know, how the partnership board, the partnership committees are constituted and the memberships, and how they interact with representation into the integrated care board. So that's work to be done. So we're asking you to approve the proposal and to mandate the ICP, well, it's not the ICP DAG, the place-based partnership DAG now to carry on that further work. So that's where we're up to. I think it's a good piece of work. I think we've listened to everybody. We've tried to come to a sensible proposal, which I think will work, you know, hopefully alongside the shadow arrangements with the board, David. So I think that's all I'll say, because you've heard it all before.
Thanks, Jeff. I've got Roy then. Graham.
Thanks, Chair. Thanks, Jeff. Thanks for that paper, by the way, and the work that you've done on that. And you know, and please pass on our thanks to the DAG for the significant amount of work that's been done to bring this together. And can I assure you, Jeff, you're never boring, by the way. it's it's a really good paper, but I think the important thing, and I think you've said this to me in the past, is that it's vitally important that we socialise these arrangements with all partners within the PBPs. What we don't want, I think, and I know, and you've said it to me in the past, is we don't want anybody coming back from those partnerships, within those partnerships, saying to us, well, we weren't aware of this, we didn't know what those proposals were. So I think if we could just ask colleagues to go back and ensure that when they have those PBP meetings, that all our partnership colleagues are very much aware of these, understand them and support them, quite frankly. So thanks again, Jeff, for the work you've done on that.
It's great, Roy. Thank you. Graham Burgess first, then Graham Gooch.
I think great, nice to think alike, Roy. And that's the thing. I sent an email now. I shouldn't be doing it in the meeting, but I just sent an email to my people in Pennine saying we need to get this report out to our governing bodies and our place-based partnerships as soon as possible, for the very reason you've outlined, Roy. I think they're excellent reports. I fully support them. Only one very slight thing, and probably it's in the appendices, talk about the role description for the place-based leader and place-based chair. And maybe this is more something that should be in the job descriptions rather than the actual report itself. But I don't think it gives sufficient emphasis that both the place-based leader and place-based partner need to have experience of managing complex organisations and also managing complex budgets. It doesn't really mention, apart from that they'll be managing some really big budgets probably, and also very complex partnerships. Maybe that's implicit, and maybe that's actually going to be in a job description or a role descriptor that comes out later. But I do think it might be worth mentioning in the appendices, so when people see these roles, they realise they are serious and big roles, and they need really skilled and experienced people to carry them out. And I don't think that quite comes across in some of the appendices and the major skills required of those roles. But I'd say it's a really good report, and I'm really pleased to see it.
Thanks, Graham. Great support. Graham Gooch, then Jenny.
Yes, indeed, a good report. One thing we were looking at, well, in essence, it seems to create like a small ICB in 5 places, which means locally there's oversight and direction of the NHS funds delegated to that place. Now, I heard Marie Burnham speak about that last week, and that appears to be the position in West Yorkshire. And it's at that place where we should perhaps expect to see strong elected member representation. Now, I know Andrew's meeting the 4 DASs to work through more precise detail of how local government can take a strong leadership role at these places. But yeah, I like the way it's going, and we look to put more into it and be fully involved.
Thanks, Graham. That's great. Jenny, then Kevin.
Thanks, Chair, and forgive me, I've only been working in this ICS for 5 weeks, having come from Cheshire and Mersey, so you may have already considered this. But I think it's just making sure that within this we consider those partners that span more than one place, and indeed all of the places potentially, and how they weave and fit into these arrangements, and make sure that we as I use Lancashire and South Cumbria, and indeed thinking of MWAS as well, best participate and work with you across all of those places.
Important point. Thanks, Jenny. Kevin.
Thanks, David. And thanks for the paper, Jeff. I want to respond with 2 hats on, if you may. Firstly, from a Central Lancs perspective, I'm fully supportive of the paper. It's been through the Central Lancs system, and the recommendations that you put forward, or the proposals in Section 5, fully endorsed and supported. So thank you for the work on that, Jeff. In terms of responding then from a provider collaboration perspective, I think the point that you made about it's the detail now that we need to get into is going to be really important, and I think the roles and responsibilities of place vis-a-vis collaboration and provider collaboration are going to be really important to work through. So look forward to working with you on that in the future, but I think it's really important now that we move on to that stage and really clarify those roles and responsibilities. But good paper, and very much endorsed.
Thanks, Kevin. I think on this last point, in some ways, when we think about what the role of the ICS across the system, our collective role across the system is to make sure that the right decisions are made in the right places, to oversimplify it, backed up with the resources. And this issue now that we've got a clear way forward on the place-based partnerships, I think it's terrific work and a clear picture about governance, and I appreciate the support expressed for this. And as Kevin, as you and other colleagues work through what the PCB is, we really do need to come together to map out how the decisions are going to be, where the decisions are going to be taken, how the resource allocation framework underpins that, and a clarity of and simplicity of governance across it. I don't want the providers to think that in another room somewhere there is deals being done between the ICS and the places which they're not part of, and could lead to a fragmentation of the system approach to providers individually and collectively. And I don't want the place-based leaders at the moment, and as we go through this transition, thinking that in another room somewhere there's a deal being struck with the PCB and all the money's going to go there and it won't properly go into places. Both bits are part of real dynamics in the new system, and we need to work through that collectively and together in a very transparent way. And now that we've got this clarity on the place-based partnerships, I think we're now in the position to be able to get on with that. So, Jeff, this, in summary, this board supports where you've got to. We endorse it. We can now, it's a significant moment for us. We can now move forward into implementation of the sort of discussion I've just described and begin the process for making appointments. I agree with Graham Burgess that the place-based jobs they're fantastic jobs in the new system. We've said that before. They have very challenging management of change and delivery roles, and I look forward to working with folks to find the right people for those roles and building them into the system. Andrew, is there anything that you want to say by way? No, okay.
No, thank you, David.
Thank you. So that's all very well done, Jeff. Thank you very much. We've got an update on the new hospitals programme, Jerry.
Thank you, Chair, and good afternoon, everyone. I shall take the paper as read, but there are a couple of areas that I would like to just share an update in more detail with you on. The first one is to confirm that the long list, the 10 long list of options for the new hospital programme have been published and have been published in combination with a very much expanded public engagement programme of work. Members will be aware that we've extensively used the big chat to engage with staff and trust members, but over the last couple of months very much extended our direct contact with the public, both through making the website, the new hospital programme website, much more interactive, but most recently with the launch and rollout of our roadshows, where we are appearing across a range of different facilities and sites across Lancashire and South Cumbria to meet the public. I'd like to actually recognise the support of Healthwatch, who have been an incredible, important partner in terms of our roadshows in helping to co-present those roadshows, and we've had some fantastic feedback from the public, both through the website and through those roadshows. It's important to stress that obviously that feedback from the public is really important evidence that will ultimately be used to help us go from a long list of options to a short list. Again, as you would expect, a very wide range of views and opinions from the public, but understandably some consistent themes around the importance of access and transport, particularly in areas of high inequalities, where understandably the easy access to hospital facilities remains an absolute priority to them. just looking a little to the current situation with the programme and events over the next few weeks, probably worth emphasising that we're now in a significant area of work in terms of starting to build our evidence base, understanding the costs of the options and how they impact on the benefits to our population and to our system looking forward over the planned period of the programme. We have been very clear in the scope of the programme that this has looked at the facilities, the hospital facilities for Lancashire Teaching and for University Hospital Morecambe Bay. But increasingly so, we recognise that the success of the new hospital programme is wholly dependent on its interrelationship with our whole system delivery. And therefore, we're working very hard now to make sure that the new hospital programme is placed within the Provider Collaborative Board and the work it is undertaking around the hospital clinical strategy, working with the Value Circle, and also recognising that over a long-term period, the success of the new hospital programme is crucially interdependent with our overall financial plan and our overall infrastructure plan. So much work now trying to make sure we bring the new hospital programme within the success of our overall system delivery. I should add a final point. It's been much of today's meeting, but I would stress again that the success and long-term success of our integrated community services, our place, and the new hospital programme is a key interdependency, particularly if we are to successfully manage care, demand and a population health approach where most of that care is provided close to people's homes rather than in our hospitals, so we can focus them on delivering that specialist care. I hope that's a useful summary, Chair, and happy to answer any questions.
Thank you very much, Jerry. Before I open up, I'd just like to ask Kevin and then Aaron, anything to add from the two trust perspectives, Kevin?
Jerry's given a very succinct and very good summary of where we are. I'd just emphasise again that point about the new hospitals programme now is moving into a phase where we need to anchor it very much in the overall clinical strategy for Lancashire and South Cumbria, so it plays its part and is not seen as something separate. And Jerry is absolutely aware of that and is positioning the work appropriately. So now I'm very pleased with where we're up to. Significant progress has been made, I think, in the last few months, and I'm looking forward to the continuing work.
Thank you. And I'm sure other colleagues will have noticed, as well as I've done, Kevin, that for this item you've put a background on your picture today that shows the inadequacies of the entrance to the emergency department in Preston. It's duly noted. Aaron, then David.
Thanks, Chair. I've been busy trying to create a montage of similar backgrounds for the RLI and FGH to compete, but I haven't figured out how to do it as a screensaver yet. I think, joking aside, I think this next phase for us is the exciting bit of the new hospitals programme, which is getting into some proper conversations with our clinical leadership, operational leadership, the clinical strategy discussion, to start to build what the solutions under that new hospitals programme budget could look like between us. It's great. Obviously, we had a continued relationship with Karen and Ibby at LTH, and Kevin's continued that now with good joint partner discussions on what this could look like between us, not just adding it both together at the end and coming up with a solution. So I think this next few months in particular is quite an exciting time to get into the oft-used term out of the possible under that clinical strategy discussion. It's progressing well. This next bit's going to be where the decisions get taken or moved on.
Thanks, Aaron. Got David, then Andrew, then Jeff.
Thank you, Chair. So just a couple of points on this one. Obviously, this is this programme is of massive importance to the public, and we've certainly been contacted. We're really delighted to be involved in the engagement and trying to make sure that as many people as possible have a say on these kind of things. We have been contacted by some groups and individuals that have got a range of concerns about this. Understandably, there's a level of anxiety about what this means and could mean for some of the services, other services locally. In particular, the people that we've been speaking to, there's around 30 individuals. They've asked for a further meeting with some kind of system leaders to discuss some of their concerns. we'd be very happy to facilitate that. So happy to pick that up offline with Jerry and Andrew and others if that's something that people are interested in. I think one of the things that's of concern for people is that the engagement is very much focused, and we've said this before, around where the buildings might be. But there's a kind of growing concern about what the services that would be in those buildings might look like. So I think that there is a general feeling that it's very difficult for people to have a very meaningful say on where buildings might be located, and when with the lack of the clinical strategy or a really clear description of what services might be available in which sites, etc. So I think that's generally where the public concern might be. Really happy for us again to be involved and continue working with you to try and kind of broker conversations. And I think it would be remiss of us not to open up some of those issues and discussions with people before we move out of an engagement period. I'm very happy to facilitate that.
Thanks, David. Very welcome. I agree with you. Andrew, then Jeff.
Thank you. I just wanted to briefly endorse the point that Jerry made about the wider service strategy, particularly for services in primary and community environments. And there was a connection between that and Isla's comment on the previous discussion about thinking about what we sometimes say is out of hospital services, but the way that we organise those services and how they would interact with a new hospital model of care. And as Jerry was saying, there is quite a lot more that we need to say around that, set out around that, and think what are the complementary actions that we need to take. It's going to provide a real focus for us over the next couple of months, I think, to try and articulate that and then make the connections to this new hospitals programme. So just to confirm to the board, we need to take that forward.
Thanks, Andrew. Jeff, then Jackie.
Thank you. The danger of speaking last is what you want to say is said by others, but I'm going to say it anyway. But the first thing I want to say is it does feel like I'm part of a really good, proper process. Yeah, it was a bit of a shaky start, I would say, to getting involved in the new hospitals programme, but it doesn't feel like that anymore. So I think well done to Jerry and his team. It really feels like that it's a decent process, and I think that's important to say in a public meeting. So I think I've got confidence in it. The thing I wanted to say was just what you said, Andrew, and others. It came up last night in the clinical oversight group. So I think this is a task that's going to be brewing with Lindsay and Peter's involvement, and I think it's quite a big task. But I think we now, after fighting a rearguard action to try and get primary care into what was called the HIP 2, and there's now new hospitals programme, we recognise this is a new hospitals programme, but we have to recognise that primary care in its estate and its workforce and the whole strategy around it needs an ICS touch. And I think it needs to run in parallel, because the new hospitals programme will fail if the clinical strategy in primary care doesn't match it and be there to receive what doesn't go to hospital. So it's just a recognition of what Jerry and Andrew have said, really, and I think it's a really important thing that we develop some resource and time and focus to it. Thank you.
Yeah, point well made, Jeff. Thank you. And Jackie.
Yeah, thank you, Chair. I suppose I just wanted to give some assurance to the board around the work that's happening with Southport and Ormskirk, because obviously quite a number of our Lancashire population goes that way. We have very much been working with the new hospitals programme. We are really trying to link in with that clinical strategy to make sure there are no gaps and no duplications, to make sure that actually we are very cohesive in that respect. I know the commissioners for the new hospitals programme have very much been talking about the need for that out of hospital strategy. And we were looking as commissioners to start some of that work. So hopefully we can tie that up with what's coming out of here, out of the board. Just to come back on David's point as well, we have met, I think Jerry and I have met with some of those residents that you're talking about, maybe that have got some concerns again, to make sure we can have the conversation about how they can get their points across, both in terms of the estate solutions and in terms of the service solutions. But I'm sure Jerry and I will be, open to doing that again, David, if there is a need to engage. Thank you, Chair.
Thanks, Jackie. Very helpful indeed. Jane.
Thanks, David. Again, I just wanted to pick up what David had said. Really important to continue that dialogue with groups and patients and citizens. But of course, we're an engagement part of the process, and as Jerry will be able to add to this. Once we get to consultation, we'll want to talk even more about some potential changes if they're part of the solution. So it's not the only opportunity to have that conversation. That dialogue must continue, and we're in engagement phase now, potentially consultation if that's necessary in the future.
Thanks, Jane. Right, Jerry. So everything's noted. You feel encouragement and cheering you on from this board. The point that David's made about some of the engagement, please pick up outside of the meeting in the way that Jackie and others have suggested. We can see in your paper what the priorities for the next period are, and look forward to receiving the update here in due course. So well done, Jerry. Right. We received for information only the highlight report from the system development programme. They've not been notified of any other business for today. Does anybody wish to flag any items for future agenda that we don't think that we're picking up properly as a system? All right, thank you. So we meet again like this on Wednesday, the 12th of January. Undoubtedly, in our next meeting, there'll be a continuation of the discussion of some of the themes that we've covered today. We'll see where we get to then. I thank you all very much for your attendance at this meeting in the context of how busy and pressured it is, and also for the contributions that you make. It feels to me that we're a group of people from all parts of the system working together on the things that matter most for our patients and our population. You've all recognised in different ways in your contribution the incredible work that's going on in all of the teams in all your organisations, particularly those in the patient-facing parts of the system in primary and secondary care, and we acknowledge how tough it's been and how tough it's going to be, and our duty is to support people as very best we can. And I think in some of the discussions that we've had today, we've highlighted a number of areas that we'll continue to focus and work on. So thank you. I've given you 8 minutes that you didn't think you'd have by finishing slightly early. It doesn't quite counterbalance all the extra time I've taken in the previous 13 meetings, but it's a step in the right direction. So thank you all very much indeed, and see you next time.
Thank you.
Bye.
Right.